Go.
Good afternoon, everybody who's come along to this webinar run by the Centre for Dementia Learning. My name's Garrie O'Toole. I'm one of the facilitators at the Centre for Dementia Learning at Dementia Australia, and really pleased to see all of you come along for this very interesting discussion that we'll be having today. I'd first like to acknowledge the traditional owners of the land on which we meet today, and I'd also like to pay my respects to elders past and present and to our shared futures. Today our topic is intimacy and sexual expression in aged care, and we have two wonderful guests, Jenny Fitzpatrick, who's one of the dementia advocates. I'll introduce Jenny in a little more detail in a moment, but also Cindy Jones, who's an academic with a particular interest in sexuality and ageing and the aged care sector. I'm here really just to make sure that the webinar keeps running smoothly. I won't be hopefully having too much to say, but I did want to just introduce our topic, I suppose. And I suppose the area of sexual expression, sexuality, intimacy in more general terms is something that's often difficult for us to talk about in the best of circumstances, or for many of us to discuss. And it's particularly complex and sometimes challenging when we throw in the aspects of ageing, of dementia, and particularly the area of aged care support, whether that be in the community or in residential aged care. My background is in nursing, and I know that although in nursing we have for the last 40 years talked about the provision of holistic care, I can't remember in my nursing training or even post my initial nursing training ever actually being taught or educated in the areas of intimacy and sexuality. And I know that in the residential aged care sector that very often our assessments don't even include questions about sexual expression. It's almost like an area we don't want to know about. And as a man in his mid-60s now, somebody who perhaps will be a consumer of aged care services in the future, it certainly is something that worries me in the future for my own care, and certainly my experience of working with residential aged care services and community services. I think it is an area that often provides great challenges. As I said, it's not something that we talk a lot about, though there has been quite an increase in discussion around sexuality in the last few months, and I think particularly with the introduction of SIRS, the Serious Incident Reporting process, we've seen a lot of discussion. What struck me in that discussion is it tends to be around a negative framing of sexuality. It's largely a discussion around sexual assault, the risk of sexual abuse, and these are incredibly important and critical issues for us to discuss. But I suppose when we were talking about the seminar that we wanted to run at the Centre for Dementia Learning, we wanted to have a more positive focus, a focus on those life-affirming aspects of intimacy, of sexuality and sexual expression, and that's what we want to focus on today. So I'll move on to introduce Jenny Fitzpatrick, who's the first of our guest speakers today. Jenny is or has been a dementia advocate at Dementia Australia for many years and been involved in advocacy and research at Dementia Australia. She's also been very keenly and actively involved in ADNET, the Australian Dementia Network, and I know that she's found that extraordinarily useful and valuable use of her time. Her husband, Noel, was formally diagnosed with younger onset Alzheimer's disease in January 2009 at the age of 59. Both Noel and Jenny have worked tirelessly to raise awareness about dementia since that diagnosis. Noel's currently a resident in a residential aged care facility in New South Wales, and I think Jenny was saying to me just before we started that he's been in that facility now for 9 years. So I'd like to hand over the microphone to Jenny. If Jenny could just tell us a little bit about her experience with Noel and with the aged care service sector, particularly around the important aspect of intimacy in their relationship. Over to you, Jenny. Jenny, you're on mute.
There,
thank you.
Thank you. Let's try again. Thank you, Garrie. So Noel and I married 30 years ago in September this year. We don't have any children. That's just a snapshot of us. Noel became psychotic and was admitted to Concord Hospital in June 2014. He's now doubly incontinent, unable to communicate verbally or walk. He requires feeding, a minced and moist diet, and frequently has swallowing difficulties. However, Noel hasn't disappeared. He is very much alive and his spirit shines through. I'd like to say to begin, and I should have started with this, that I feel humbled to be with this audience. You are people for whom I have the utmost admiration and gratitude for the work that you do. Thank you for caring for our loved ones. I don't pretend to be an expert, but I bring our perspective and our understanding through our long 15.5-year journey with Alzheimer's, younger onset dementia Alzheimer's. I'm going to talk about 5 aspects of intimacy and just quickly going through those. The physical intimacy, actual sexual expression for us has not been part of our relationship since well before Noel went into care. But physical is still really important. Touch releases feel-good hormone, the feel-good hormone of oxytocin, and it's so important for the well-being of everyone. Emotional intimacy with genuine sharing, being seen, known and felt, and feeling comfortable, safe, and the trust that builds between people. Intellectual intimacy, which is about openness and trust, being valued and included in conversations, events, etc. There's experiential intimacy, shared experiences, names, stories, places, photos, events, and spiritual intimacy, shared religious rituals, sharing of nature, enabling a transcendent connection. So to begin with, I'm going to tell 2 stories from the beginning of our relationship, a journey with Alzheimer's, and a recent one. Noel said one night, soon after he was diagnosed, "Everyone has something in their lives to contend with. This is ours, and we'll manage it with grace." Noel knew we were in it together. He hugged me. It was a profound moment, I think a profound moment for both of us. And I knew in that moment that I needed to step up to be with Noel and to reflect the attitude or imbibe the attitude that he had. Another story was he'd left a piece of paper, bright blue paper, like the shirt that he has on there, and it read, "A thought, Jenny, a thought. As my disease takes over, I will depend on you more, and that will mean my capacity for dependence will increase and my capacity for unselfish love may wither away. He left that, and then Noel. He left that note on the lounge 3 years after he was diagnosed. And that reflects his massive insight into his disease and its impact on me. It's stunning, and it still fills me with awe. That love and closeness with me, it is still there all these years later. A month ago, Noel had another seizure. After a few days, began crying a lot and trying to talk to me. He barely communicates in words now. Each time we were alone in a quiet spot, when we stopped, he began crying, then trying to communicate with me. And tears. I reassured him about my love, and I talked about his long struggle with Alzheimer's, but his brain was very damaged now and his body was tired. Back when I was still working, Noel had confided in a friend in Melbourne and asked her to look after me when he died because he was worried how I would be. With that in mind, I spoke about myself, that I was sad and okay, that I would continue to be with him. I promised that I would live a good and happy life after he died. And he reached over, put his hand behind my shoulder and drew me to himself and held me. He has rarely, if at all, done that since before he went into hospital. He hasn't liked to be hugged, to be contained in any way. He communicated through murmuring as he held me, and we had a conversation amid our tears. It was a powerful moment of intimacy, of love and feeling loved. It was 2 weeks later that it dawned on me that Noel hadn't cried since, and he still hasn't cried since. That remains the case. He's at peace. He was worrying about me, and once I'd made my promise to live a good and happy life, he has been able to release that concern, a burden lifted from him. Noel still loves and cares about me, and that experience was beyond my imagining. These are examples of physical and emotional intimacy. Changing gears now, and this involves staff. I have to say that I've sought permission and received permission and support from all the staff that I've asked to name. Well, I'm not actually naming them. Noel was refusing to be changed when he obviously needed to be. Part of dementia for so many people, as you're all very aware. This day I was there, and after he eventually agreed to be changed, he sat on the bed next to me and said, "It shouldn't be allowed." He was feeling violated, even abused. I told his geriatrician, who is professional, faithful to us and quite fond of Noel, and she said, "You know, Jenny, that's not true. He needs to be changed." I explained that that's true from our perspective and logic, but at a feeling level, Noel was being undressed and touched in ways that were to him inconceivable, abhorrent, and unacceptable. She really listened to what I was saying, as she always does. I am in no way suggesting there was any abuse. I'm merely telling you how Noel felt about what was happening to him. Several years later, one of those same staff members who has been working with Noel for most of the 9 years had just changed Noel. Noel no longer is able to walk, and he was in the lifter, in the sling in the lifter, while waiting for Leo's partners to prepare his wheelchair. All was calm and quiet when I witnessed the most powerful moment. Noel looked over at Leo, reached out his arm and beamed lovingly at him. Leo smiled back. I was witnessing Noel expressing his gratitude and affection for Leo, and Leo was responding. It was a moment of intimacy, a far cry from the time Noel said that it shouldn't be allowed. When I asked Leo if he was comfortable for me to share that story, he said yes, and then spoke about how he often feels Noel watching him, reaching out to him, and even trying to talk with him. Leo feels acknowledged, honoured, and appreciated. These stories are a powerful witness to the level of intimacy a person with dementia has the capacity to experience and express. These are both physical and emotional intimacy. Another recent staff story was when Noel had been in bed a couple of days after his recent seizure, and this was for an unrelated reason. He'd had a rough couple of days. He was sitting up in bed and I was feeding him his lunch. Beatrice, a relatively new staff member, came in to check on us. We chatted and she stood at the top of the bed and began running her fingers through Noel's hair and speaking quietly and warmly to him. She called him by his family name, Roly Poly Nolly. That was the name his mum gave him when he was a baby, and he still used affectionately at times. Suddenly Beatrice looked at me, a bit embarrassed, and said, "Is it all right for me to call him that? I hear Maria use it." I smiled and said, "Of course it is." It was beautiful at so many levels. I was touched that Beatrice used it so gently and affectionately, and that she had learnt it, or more truly absorbed it, from her experienced partner, who had been working with Noel for these whole 9 years. When I hear Maria use it, it melts me. Roly, roly, poly. It's an intimate family name and always used with love. As with Leo, when I asked Maria and Beatrice if I could tell this story, they chatted about the way Noel reaches out, watches and engages with them. He makes them feel special and appreciated. Noel is able to engage in intimacy. It is not a one-way street. And so that's physical, emotional and experiential, because it's a family name. I have 2 other funny stories that might change, but I'm checking in. Should I stop for a while?
We'd love to hear one of your funny stories, and I'll come back to you a little bit later and you can tell us the other one, please, Jenny.
So this was mid-2020, after we were back after being locked out, banned from entering and being with our loved ones. Noel laughed. It wasn't my first visit, but Noel laughed when he saw me. A delightful start, I thought. I took him upstairs and, as usual, wrapped him in his scarf due to the breeze. He leaned forward and placed the end of his scarf across my masked face and laughed. I was quite shocked at his level of cognition. I proceeded to unhook my mask, smiled and chatted to him, and again he placed the end of his scarf across my face. He looked at me in the eyes and laughed. I was stunned by his understanding of the mask, his humour, his gentle teasing of me, his fine motor coordination, and his deliberate engagement with me. It was amazing. And Noel enjoyed teasing me. So it was just a very Noel and I story. So I will hand over to Garrie, I think.
Thank you, Jenny. Thank you. And Jenny, I have the privilege, I suppose, of being able to see the Dementia Australia team on screen, and I have to say that there were tears in just about every eye. So I really want to thank you for your courage and your honesty in sharing those stories. And just before I'll come back with just a couple of quick questions, but just I've been remiss in my housekeeping. I just want to remind our audience that they do have the ability to ask questions in chat. And we have the lovely Liz Keating monitoring the chat. And you can also like a particular question in chat, and that will raise the profile of that question. And we'd love to have some audience questions to be able to send to Jenny and to Cindy as we continue the discussion. So please take advantage of those Zoom functions. Jenny, just a couple of quick comments. And again, I said at the very beginning, I've been a nurse for a very long time, for over 40 years, and I'd never heard of intimacy talked about in those 5 categories that you mentioned. And just from that sort of intellectual point of view, I found that really a lovely way of framing what we're talking about. And the other thing that the thing that stood out for me of all of the beautiful stories you told of you and Noel was that his capacity, even late into the disease, to understand, to have insight into the importance of intimacy in your relationship. And I think sometimes with the sort of very almost nihilistic views that we sometimes have about dementia and a diagnosis of dementia, there can be a feeling that it doesn't matter. They don't understand. They won't remember. And I think that story you told is just such a beautiful example of how important intimacy is in all of our lives, and how people do retain, particularly, I think, an insight into that deep emotional connection that they can have with people in their lives. So thank you for sharing those stories. And we don't have any questions, I don't think, Liz, at the moment. So
not as yet, Garrie.
Okay, thanks, Liz. So, look, what I might do is just introduce our second guest, Dr. Cindy Jones. I'm sure many of you will be familiar with Cindy. Cindy is a very experienced health researcher in with a primary focus on social and behavioural science research, particularly as that relates to older people, and particularly around behavioural and psychological symptoms experienced by many people with a diagnosis of dementia. Cindy's a leading national and international educator on sexuality and dementia in Australia, and is committed, I suppose, and has shown her commitment to improving knowledge, attitudes and care practices of health professionals towards the expression of sexuality by people living with dementia in the aged care sector in Australia. So thank you, Cindy, for coming along. I know you're very busy and had to rush from a lecture to our webinar this afternoon. So we really thank you for coming along. And I'd just, I suppose, like to hear from you your reactions to Jenny's stories about her relationship with her husband, and what your research has shown in terms of some of the barriers and some of the opportunities within the aged care sector, both residential and probably more acutely in the residential aged care sector, to supporting sexuality, intimacy, sexual expression in older people with dementia. Cindy.
Okay, thank you very much, Garrie, for the introduction. I'm going to start by expressing my gratitude to Jenny for sharing her story. This is not the first time I've heard it. We had a meeting prior to this session, and both times when I hear about Jenny describing her journey and her experience with her husband, at both times it brought tears to my eyes. So yeah, it's a very touching insight to the relationship that you have. Now, I'm going to start off by just sharing something that maybe some of you have went through the same journey as I did when it comes to the topic of intimacy and sexual expression in aged care. I was a fresh PhD graduate 15 years ago. I was asked to do work in the area of aged care. and I was tasked with this topic on intimacy and sexuality. I was relatively young back then, not giving away my age, but the first thought that crossed my mind is, really? Older people, intimacy, sex, aging, sexuality? Is it that important? Do I really need to look into this area? I was literally cringing in there, thinking, isn't there a much more important topic for me to do work on, to research, to inform care practice? This is an area, a topic that is last on my priority. And I have to say, when I reflect to my reaction that I had 15 years ago, I come to realize that over the last 15 years, this has been an incredible journey for me to realize that this is an area that is like the elephant in the room we don't address, but it's an area of concern. And I think when Jenny described intimacy and sexual expression, the way she framed it across the 5 areas of physical, emotion, intellectual, experiential, and spiritual, very much validates some of the work that I've been doing in educating aged care staff in this area. That often when we look at intimacy, sexual expression, people are quick to jump to the conclusion that these are behavior that are challenging, problematic, inappropriate, it got to do with sex, etc. But if we unpacked a little bit more about what is it about intimacy and sexual expression, it's not just the sexual relationship, it's not the sexual intercourse. Underlying it, we need to understand the drive, the motivation behind those behavior. And when we talk about intimacy, ultimately, we want to be able, as a human being, to connect with someone, to have that sense of connection, to be free from loneliness. And I think, Jenny, I know it's beautiful that you have that with you. But if we think about it generally, does everyone in the nursing home is as fortunate as Jenny and know? And as a result of this unmet need, the need for intimacy and connection, sometimes some of their behavior can be misconstrued as inappropriate, challenging. So it's about that mindset change. Now, that being said, without drawing into like a lecture or educational session, I would have to say that in Australia, over the last 10 to 15 years, we have made progression in this area. I think there's a lot of work and awareness that has been done to raise awareness of the intimate and sexual expression needs of older people, both living in the community, in the aged care sector, and how we can support them. I mean, clearly I've been doing work in education in terms of training health professional in getting them to understand that there are still needs. It's not like a switch that because you're 65, you enter into a nursing home, or you have dementia, is a switch that is off, that you no longer have the need for intimacy, the need for connection, the need for sexual expression. It doesn't work that way. We are human beings, that need remains with us. Now, how we choose to express it can vary between individual to individual, and how important the needs are can vary. So in my work with residents with and without dementia living in a nursing home environment, some people, it remains a very important topic, important need that is not met. Some may not choose to be that engaged or so interested about it. But for those that do have that need, we need to ask ourselves as healthcare professionals whether we are addressing that need in a care environment. So I know we have training. I know some of my colleagues in La Trobe University over the years have created resources to inform people living with dementia and their family about this area of need. So there have been work in that area. And personally, one of the key things is being about proactive in addressing need. I think Garrie at the beginning did mention about this reporting and how it's quite alarming if you read into some of the report, some of the behaviors, etc. But often when we hear about this incident of behavior relating to intimate or sexual expression, we are quick to label or put them into a too hard basket or something that is challenging, inappropriate. But have we considered what might be the trigger, what might be the unmet needs that might lead to those behavior? So that's one question. And have we been proactive enough to reach out to our residents to ask them what is their need in this area? So another aspect of my work, which I was very fortunate to be funded by Dementia Australia Research Foundation, is to develop an instrument or a tool to initiate those conversations between healthcare professional and residents in terms of their intimate and sexual needs. And we just completed this work. There's a website with the tool that is readily available and user guide in terms of using it. So I guess what I'm trying to say is in Australia, we're fortunate. We have been working and trying to address this area in the best of our ability. But I think it remains to be an area that we could put in more effort. And it's not consistent across all the different aged care organizations, but we are definitely on the right trajectory. And the fact that we're even having a conversation today to share experience, to talk about it, really demonstrate our commitment and our desire to be supportive in this often quite challenging conversation to have in supporting residents in this area. So I'll keep this really short in terms of what I'm doing, but I think hearing from Jenny, it's really heartwarming, and especially when I hear about that connection that you have with not so much the sexual aspect, but the physical, the touch that you highlighted, the emotional. And it's amazing to see that even with a person with dementia, that craving for that intimacy, that physical connection can still remain, and they can still so poignantly articulate it in a note to Jenny. And we can never underestimate that need, and that we could not be dismissive just because they have, they are in care or they have dementia, their need is gone. I think that's clearly reflected in the story that Jenny has been telling about her and No. So I'll just stop there in case Jenny or Garrie or the audience has something to add to that.
Thank you, Cindy. There's so much in there. I don't know where to start. Look, there are a couple of things that before we throw to questions, and we do have a number of questions. I loved the idea that you spoke about, that intimacy, sexuality is that the desire, the need, the drive for connection, and that idea of being free from loneliness. And we know that the research shows very clearly that isolation and loneliness is a scourge for older people in our community, and particularly for older people with the diagnosis of dementia. And I was just very quickly reminded of some of the models for person-centered care out there, the Eden model that talks about some of the I think they refer to plagues or the scourges of loneliness and isolation, and that the whole purpose of care is to try and address some of those dangers, those losses that people experience. And I'll make one further comment, because people can't keep me quiet about these sorts of topics. And the connection you made, or just briefly made, and I may have got the wrong impression, but between some of the reports we're seeing as a result of the CERS reporting, and really digging into the triggers for why we're seeing such high incidences of sexual assault and sexual abuse within the aged care sector, and looking at triggers. And I hadn't quite made that connection in my head just yet, but perhaps it's because we're not brave enough yet within the sector to really address the intimacy needs of our residents, and particularly residents with dementia, that in itself is the trigger that will for a lot of, or some of, the inappropriate expressions of sexuality that we see. And that we're perhaps looking at a structural trigger for some of these reports we're seeing. It's a speculation. I don't have any evidence to support it or to back it up, but I think it's a really fascinating thing to think about. So thank you for certainly stimulating my brain cells further. I might just ask Liz if there are any questions from the audience that we can perhaps ask either Jenny and or Cindy.
Yes, absolutely. Thanks, Garrie. There's been quite a number of questions coming in. Thank you for your responses there. One of the comments, I'd just like to acknowledge, Jenny, there's been a lot of comments coming in on your description of the different types of intimacy, and people are saying that's been extraordinarily helpful. So thank you for that. One question that's come up, just looking at the chat here. Where do staff stand when the aged care provider, religious foundations, will not acknowledge intimacy or sexuality in the older person? So if that particular facility perhaps does not have any policy or guidelines, despite numerous staff coming and going over the years requesting the same. What are your thoughts? And I'll throw you back that one back to you, Garrie.
Thanks, Liz. And I think this is something that we can get some very fruitful comments from both Jenny and from Cindy. And I think I may ask Jenny first to comment that obviously you've found support within the aged care service that's providing Noel with care, and perhaps haven't quite had that experience. But what do you think from a carer's, a loved one's perspective, the options might be, or the responses might be when a facility is having difficulty with this aspect of one of their residents' lives?
Not sure entirely. Are we talking about two residents who become friends and closer and then intimate? Is that what we're talking about? Or
it's a little hard to tell, Jenny, from the question, but I think I would broaden the question out a little bit and talk about just some aged care services just have difficulty with the concept of intimacy altogether. And just before I throw to you, Liz was going to reflect on that question, I think.
It was just there's an absence from the question. We can glean there's an absence of policies or guidelines for particular facilities, and I know that we've come across that in our experience, Garrie.
Certainly. Jenny?
Okay, so when Noel and I first went to the nursing home, because we were much younger, Noel was 63, I think, and I was 59, something, I don't know, 60. And we were offered to bring our own bed if we wanted to. We didn't need to use the bed. And I imagine that was because the manager thought that we would still be sexually active. And I suppose I might have been a bit shocked. And she said, Jenny, we've seen it all. I've let prostitutes come. Well, she didn't call them prostitutes, but people offering services to come into nursing homes that I've been in charge of. And just because people are in care doesn't mean they can't be sexually active. So that was a bit of a shock to me.
Yeah, we do have a point on that, Garrie. A couple of points on that. Sorry,
please go.
You're going to say?
No, go ahead, Liz.
Great. We've got a comment here. We have a policy that's been sent to that particular area from ACCPA, which states the organisation commits to facilitating access to and the use of sexual aids, equipment or visuals and services, as Jenny's just mentioned, of the intimacy, a sex worker perhaps. Amanda has then followed up with how does that go, as obviously they need to protect their workers. They may not cope with being exposed to those kinds of things. What are your thoughts?
I might throw that to Cindy, particularly that question of the rights of workers and the levels of discomfort. Sometimes there are cultural barriers to be engaging in this sort of care. How do we address some of those issues?
Yeah. So I think there's a couple of things to unpack from the question just now. So I think the first question was about what happens if we have a religious organization that doesn't have a policy and is not supportive. I think this is not surprising that the question came up. Because I don't think it's just limited to religious organization. I think there are organizations that can be, I would say, closed off or guarded about any activities or behaviors relating to those area in residents. So it's not just limited to religious organization. And what can we do about it? Well, unfortunately, a lot of it, our hands are a little bit tied right now because there's no really very explicit care standards or practices that particularly address this area. It's up to the individual organization, and hence this conversation we're having, conferences, webinars, training, is help to stimulate this type of discussion that eventually will get organization to recognize. And this behavior is not going to go away. It's going to become, I wouldn't say more rife, but you know, we are working with a different generation of older people. They are more expressive. So I would say that eventually someone's going to have to, if an organization have been trying to avoid this, it's not going to go away. But do I have a clear solution to it? Probably not at this point. So it's about advocating, talking, discussing to promote awareness. So we are sort of on the right direction. There are things. But that being said, I have known of some organization that has been very proactive. They have started looking down policy, training for staff. It's happening. And I have seen the change in the shift of over the last 5 or 10 years. But unfortunately, there will remain some aged care organization that haven't quite get to that point yet. So that's that first part of the question. Now, the second part of the question about where does staff come into if there's policy and, you know, looking after, I guess, the well-being and the scope of practice for of staff in aged care sector. Now, one of the things interesting I found is sometimes organization can have policy, but staff may not be aware of the policy. So that's one area. Now, obviously, with that question about, you know, using sexual aids, I think that was the way it was phrased, to help facilitate those behavior, and where does it leave staff, and in terms of those that are not comfortable with assisting or cleaning or managing those aids, where does it leave them? Now, my first thought is, has there been training in an organization for staff before that policy was implemented? Have there been open discussion between staff? Hey, I got this policy now. This is what we're going to implement. What does it mean? Where are you concerned? And address it. Now, it's a really a hard area, because at the end of the day, as aged care staff, we are there to provide a service and care. And part of the care is about if we look at those aids, that sexual aids as a clinical instrument, then it would have been fine. But nevertheless, I do recognize that there are staff that is challenging or challenged by those gadgets or aids. And it's about really talking to staff, addressing their concern, and perhaps if there's staff that is really not comfortable with it for whatever reason, cultural background, etc., that there may be other staff. I can't imagine that the whole nursing home, all the staff would be opposed to it. There may be those that may be more open. It's finding out who, and having a process that we know what staff need to do if they are not comfortable. Who are the ones that can be approached if those practices are being implemented? So my first question to those policies is, have there been discussion and training?
Thanks, Cindy. I think that really, really important is, how can we expect staff to be providing this sort of support when, as you say, very often there may be a policy within the organisation, but hardly any of the staff know about it. And B, we're simply not properly or appropriately preparing staff to be providing what I referred to at the beginning of our discussion as holistic care, and sexuality, intimacy, the whole range of human behaviours is an important part of my whole being, I suppose, as a human being. I think you're absolutely right. They're two critical areas. And I want to acknowledge something that you've said, Cindy, and certainly Jenny has supported, is that many aged care services get this very, very right. There are some brilliant examples of organisations, both from the faith perspective and from the more secular perspective, I suppose, who have extraordinarily positive approaches, and perhaps we should be learning more from them. So I really want to acknowledge the good work that's being done. Liz, are there any other questions that have popped up in the chat?
Yes, absolutely. What are the categories? Actually, they wanted to, there was someone there that wanted to recap on Jenny's different categories of intimacy. And then I'll move to one. We've been flooded with questions, actually, Garrie. So if Jenny could recap those categories on intimacy, and then I'll move on to the next question. Please, Jenny. Thank you.
Thanks, Liz.
The first one was physical, which is, of course, sexual, but doesn't have to just be that. Any sort of touch, and that releases the feel-good hormone of oxytocin, which is important for our well-being. The second one was emotional, and that was genuine sharing. It's about being seen, being known, being understood, feeling comfortable, feeling safe, being able to trust, and feeling trusted. The intellectual one is about being valued in conversation. I mean, I've narrowed these in terms of dementia. So obviously intellectual is about all sorts of things, but in this context, openness and trust, being valued in conversation and included even when the person may not be able to contribute verbally anymore. Experiential, just knowing the person, knowing that we've had shared experiences, names, as I talked about, stories, photos. Noel's room is filled with photos, and I'll often start chatting about those. So start talking about events in his life. And then there's spiritual, which is the shared religious rituals, sharing of nature, and that enables that connection that's at that transcendent level.
Thanks for sharing that, Jenny. And I think it provides a really really expansive framework for us when we're thinking about intimacy. So thank you, Liz. Any other questions?
Certainly.
Oh.
Absolutely, it certainly does. In fact, one of the comments there, if there was one thing you'd like healthcare professionals to know about connection with people with dementia, what would that be? And I think, you know, the different aspects certainly addresses a lot of that, particularly the emotional aspect. Would you agree, Jenny?
Yes, and can I tell a quick story?
Please
Sure.
do.
I won't read it, but Noel likes food, and so the kitchen staff like Noel. And he's vegetarian, so there's sort of a lot of fuss around his food. And he was walking. Noel used to walk constantly around the upstairs courtyard, and I'd let him wander ahead. And I was watching him, and he was standing with a group of staff from the kitchen. And I just watched. He stood, and they opened out the group to incorporate him, to include him. And they were talking and laughing, and Noel was part of it all. And then he came back to me and he said, with a big smile, I've been talking to, and he wouldn't have said kitchen staff, but I've been talking to them. And I just smiled because he had not opened his mouth, but he had been included and made to feel part of the group of people. So it was an ordinary setting. They were on lunch break. They are not his carers. They're the kitchen staff. Every single person in a nursing home is part of the care team. And I think that incorporating of people and making them feel emotionally connected, a sense of belonging, that brings in so many aspects of intimacy. And these guys don't even know that happened. But it was just such a beautiful moment for me to watch and for Noel to experience.
Thanks for that story, Jenny. And it's interesting, Liz and I were speaking to a group of aged care workers in regional Victoria just yesterday. And we had a very similar discussion, and one of the participants, something along the lines, was saying, you know, if any member of staff says, I just work in the kitchen or I just work in the laundry or something or other, I'm going to slap them, because they're such an important part of the team. And it's that, again, that opportunity for intimacy at all sorts of different levels. that are opened up when staff see themselves as having such a positive contribution to make to their residents' lives. So thank you for that. Liz.
Thank you. Thanks, Garrie. We've had, as I said, a number of questions coming through, and I think that this might speak to, going back to Cindy's comments earlier, we've had a couple of comments come through. During training, staff are told not to allow residents to hold on to them. This leads to staff not offering intimacy. How can we change this? And on from that, we've had another comment come through while we're on that topic. During one of the visits to an aged care facility, an experienced staff member came to this person who's made this comment or has this question and mentioned that they should not be going closer to that client as that client tries to touch the care staff. The question for you, Cindy, is, I beg your pardon, is do we consider any types of touching by the clients as intimacy touching or someone seeking for care? Someone seeking care.
Whoa, okay.
So identifying the differentiation between touch and care.
Okay, I think there is so much to unpack in that couple of comments. First thing is when I heard about the comment that in training, staff are told that they are not to let residents hold on to them. I personally find that quite an alarming statement to hear. When you say hold on to them, in what capacity are we talking about? If you're guiding a resident in a walk, you might hold their arm, and even if they hold their hands, I mean, these are normal human connection that has no sexual innuendo underlying it. So I would find it very challenging. I would like to understand how that training was done and in what context, because I personally find it challenging to hear that residents is not even going to be allowed to hold on to them. I mean, that is all part of the care that is required. That I think at some point you're going to have to let residents hold on to you, whether it's for walking or for assistance. And if it's nothing that the staff is not expressing it to be a concern, that they understand it's just a human connection need from the resident, I don't see it necessarily making it something bigger than what it needs to be. That's number one. But obviously I wasn't there to hear the training, so I don't know in what context that statement was made. But I do find it really interesting. Now, the other thing is try to so that residents do not try to touch them during care. Now, this is quite interesting because I think they raise a interesting point about how do we know a resident's touch is due to a need for connection, or is it for sexual underlying reason? Now, we got to think about sometimes how we provide care to residents, especially in hygiene care. We might just go in and say, hey, Mr. or Mrs., well, let's go and have a shower together. Does that sound right to you? Let's have a shower together. You're talking about someone with dementia that perhaps their processing of that information may misconstrue as, oh, this is my lucky day. I'm not saying that's the case, but what I'm saying is the care recipient may not understand, and they may have misconstrued, and they exhibit some behavior that leads to then the reporting of sexually inappropriate behavior. Now, I'm not saying every situation is like that, but have we considered the way we communicate when we are doing hygiene care? That's one aspect. Now, whether the touch is appropriate and inappropriate, there is always going to be inappropriate touch. I'm not going to deny that it doesn't happen, but I think at the end of the day, we need to understand why the residents may be touching them. When I say touch, is it just to hold up for that connection? Is it really stroking? Even if a gentleman stroking your hand, you know, for some it might be seen as offensive, for some it's not. So I still think going back to that training with the staff to understand, for them not to overreact in the first instance when they experience that behavior, but to unpack what might be the trigger, what might be the reason, and then to really think about if the behavior is really inappropriate, or maybe there's an unmet need that the resident is trying to exhibit that may not be as problematic as they deem to be. And I think sometimes if we have younger staff, they are not comfortable with it. That could be an issue. So I think it's come back to awareness and training that I'm not sure staff in aged care is having.
Thanks, Cindy, and I fully agree. I think it's an area, it's taboo in our society, often perhaps not enough in some areas of our society, but certainly within the training of many healthcare workers. And while you were talking, I was just thinking of a concept that I learnt about probably 20 years ago and still is in my mind, and that's the idea of skin hunger. That for some older people, some of us as we get older, I remember a story of a community dwelling older person who said to their doctor when he was taking her blood pressure, she said, you know, you're the only person who ever touches me. And that wasn't about sex, it was about human connection, and the importance of touch and connection as part of clinical care, let alone meeting holistic needs of people. So thank you for those responses. Jenny, did you want to add anything to that?
I would like to. As part of Noel's care plan, I have specifically asked for Noel to be touched.
Mm-hmm.
That the rec officers, that they put hand cream on him, or skincare cream, massage his hands, that people as they walk past might just touch him on the shoulder, or tap his side of his neck, just to say, how are you today, Noel? Because often he's bent double like that, he won't be aware of what's happening. So just for people to take a moment to be physical with him. And so I'm of the other end of the spectrum, but we've been there for a very long time. We know the staff, and I know that I'm not going into dangerous territory, and with either Noel or with staff. So yes, so I'm actively encouraging it, and thanking people when I see it.
Thanks, Jenny. I think I might get you to consult on my care plan when the time comes. Now we've only got about 3 minutes left. Liz, are there any other questions that we might be able to quickly respond to?
Yes, Garrie, one's just come through. 2 residents, suggestions around 2 residents getting closer and involved in intimacy. I think I might have opened up a kettle of worms there at 2 minutes to 3.
Cindy, you've got 2.5 minutes.
Oh, well, I often get thrown with this question. Okay, first of all, it's not uncommon to hear about experiences of 2 residents coming together. But that statement, there is so much question I want to ask, do they have existing partner that is in the nursing home or outside the nursing home? What's their level of cognitive awareness of what's happening? When they say trying to get intimate, in that sense, what do you mean by intimate? Is it just holding hands? Is it just hugging? Is it sitting next together? Or is it getting a little bit more into the moment, having sex, or what is it? So there is so much to unpack. And in asking for opinion, what do we do or what can we do? Honestly, it depends on the context. And so I guess what I was saying are all part of that that conversation that needs to have, the question that needs to ask in order to better support residents with relationship. Because at the end of the day, just because they're in a nursing home doesn't mean there's no need or desire for new relationship. But of course, we got to tread or handle it with more sensitivity and awareness when we do have spouse that is in the nursing home or outside, and also family members as well. But that doesn't mean that what family says then is the ultimate decision maker, that we have to consider the well-being of the resident in care. So long story short, I don't have the answer, but to give you a lot of things to consider. And I will encourage, there is my education resource that could be a good way to start. Yeah, So did I meet the time? I think I did.
You did very well, Cindy.
Thank you.
On an extraordinary topic and raised some very interesting things. We'd love to have a session just on this on that particular aspect. Okay, look, we need to wind up. I really need to thank Jenny and Cindy for their very honest and very open and very generous sharing of their stories and their research. To thank the team behind the scenes, Liz and Taylor and Jim, and also to thank the audience who came along and for all of your wonderful questions. We're so sorry we only had an hour. We could talk about this topic for the rest of the afternoon, but hopefully we've had an opportunity to raise some issues, to give some suggestions, and thank you very much. I just need to let you know that we will post a survey for the participants who attended. We please encourage you strongly to let us know how we can improve what we're doing at Dementia Australia with this webinar series. We'll be organising certificates for you within the next fortnight, and there will also be a recording of the webinar today that will be made available to those who registered to the conference. So for everybody, particularly Jenny and Cindy, thank you so much. We've had a wonderful time. I won't be able to sleep tonight. I'll have so much to think about, and goodbye.
Thank you, everyone.